Welcome to the Explainer. I've been hearing this exact same thing from so many of you lately. You've been telling me I really need many opportunities to practice identifying study types. I've been taking NBME forms 9 through 11, and I just keep missing a lot of these questions. I need a lot of examples, interactive, very granular, tricky examples. Well, I hear you loud and clear, and that is exactly what we are going to do today. We're going to build your rapid pattern recognition by diving into some seriously tricky examples directly from the source material.
Okay, let's jump right into the deep end with a classic tricky vignette. I want you to actually pause and lock in your prediction. So medical records from 2015 are reviewed for a BMI over 30, and then those patients are followed up to 2020 for the development of diabetes. What study type are we looking at here? All right, if you went with retrospective cohort study, you absolutely nailed it. The secret sauce here is the timeline. The researchers started with an exposure, that BMI over 30, that was already recorded in the past. Then they followed those specific patients forward in time, up to 2020, to look for a specific outcome, which in this case is diabetes. Because the data already existed in the past, it's retrospective. But because it grouped patients by an exposure and looked for an outcome, it is definitely a cohort.
Section 1, the golden rule of time. Temporality is everything. Think of this matrix as your ultimate cheat sheet. When you're staring down a convoluted vignette, the absolute first question you have to ask yourself is, what is the starting point of the researchers? If they're grouping patients by exposure, like, say, smokers versus non-smokers, it's a cohort study, and your key measurement there, that'll be relative risk or incidence. But if they group patients by the outcome, like separating those with cancer from those without, well, now you're looking at a case control study, and you always pair that with an odds ratio. What if they measure everything all at once? That's cross-sectional, which gives you prevalence.
Section 2, case control versus cohort traps. Let's learn how to spot them. Notice the granular difference between these two scenarios, because this is where a lot of people trip up. In the first scenario, researchers start by selecting 100 lung cancer patients and 100 healthy controls. They literally grouped them by the outcome of cancer, and then looked backward to ask about their smoking history. Now, in the second scenario, they grabbed 200 smokers and 200 non-smokers. They grouped them by the exposure to smoking, and then followed them forward to see who actually gets cancer.
So here is your rock-solid rule of thumb. Case control, you start with a disease, you look backward, and you always calculate an odds ratio. Cohort, you start with the exposure, you follow forward, and you calculate relative risk. Keep in mind, you can only calculate incidence in a cohort study because you're actually sitting there watching new cases develop over time. Make sense?
To really drive this home, let's look at a real-deal exam scenario. Imagine a vignette where you're grouping patients with an outcome, hepatitis A cases, against a matched group without the outcome, the controls, purely to identify associated food exposures. Since you are grouping by the outcome, boom, it's a case control study. And, as we just established, the only appropriate statistical measure for this design is the odds ratio. Section 3, snapshots and interventions, measuring at a single point in time.
Ready for your next interactive challenge? A survey of 1,000 people is conducted to assess current smoking status and whether they currently have COPD. Lock in your answer right now. And hey, pay really close attention to that word, current. The answer is a cross-sectional study. Why? Because the exposure, which is smoking, and the outcome, the COPD, are being measured simultaneously. It's quite literally just a snapshot in time. You absolutely cannot determine temporality here. Did the smoking actually cause the COPD, or do people with COPD just happen to take up smoking? You just don't know. Because of that, this study determines disease prevalence, not causality.
Section 4, meta-analyses and trial phases, handling pooled data.
Now let's talk about meta-analyses. When you see a forest plot combining, say, 9 small randomized controlled trials evaluating inhaled corticosteroids, you have to ask, why do researchers even do this? Well, the primary reason is to boost statistical power. By pooling all that data together, you essentially create one massive sample size. This improves your precision and directly decreases the risk of a type 2 error, meaning you are way less likely to miss a true difference if one actually exists in reality. Next question, rapid fire. A new drug is tested on 50 healthy volunteers to assess safety, toxicity, and pharmacokinetics. Pause and predict for me, which of the 4 clinical trial phases strictly tests healthy volunteers?
Yep, it's a phase 1 clinical trial. The easiest way to remember the phases is to think about them sequentially based on their goals. Phase 1 is all about safety and toxicity, tested in a small group of healthy volunteers. Phase 2 steps it up to test preliminary efficacy and optimal dosing in a moderate number of patients who actually have the disease. Phase 3 then compares the new drug to the current standard of care or a placebo in a huge, randomized group to firmly establish efficacy. Finally, Phase 4 is post-market surveillance, just keeping an eye out for rare, long-term adverse effects.
Section 5. Rapid Fire Vignette Practice. Let's put it all together. Let's see just how sharp you are today. An ALS screening test is offered. Survival from the time of diagnosis appears to increase by 2 months, but the actual physical disease course is completely unaltered. What specific bias is this? Lock it in. This is a textbook example of lead time bias. Because the screening test caught the ALS earlier, the patient technically lives longer knowing they have the diagnosis, but they don't actually live a single day longer overall. Now, don't confuse this with linked time bias. That's a completely different trap where a screening test disproportionately catches slowly progressive, much less aggressive forms of a disease, which falsely makes the survival rates look a lot better than they actually are. Okay, try this one. Next of kin are surveyed about the dietary fat intake of family members who unfortunately died of sudden cardiac death, compared to the family members of those who did not. What is the primary methodological concern here? Think deeply about how relying on human memory to look backwards might skew your data. So what we're dealing with here is a very specific flavor of recall bias. As you can probably guess, family members of those who died of sudden cardiac death are going to rack their brains much harder and recall fatty food exposure way more often than the family members of the healthy controls. This unequal classification of exposure is known as a differential bias, specifically differential recall bias. And let me tell you, it can heavily skew your odds ratio toward a totally false association. Section 6, the final framework, the ultimate exam checklist.
We've covered a lot of ground, but here is your 4-step checklist to apply to literally every single vignette you face. First, find the starting point. Did they group patients by the exposure or the outcome? Second, match the math. If it's a cohort, you want relative risk. If it's case control, grab that odds ratio. Third, identify the intervention. If you see random assignment of a treatment, you've got a randomized controlled trial. And fourth, spot the trap. Always be hunting for recall bias in retrospective studies, lead time bias in screening tests, or observer bias, which, by the way, can be totally fixed with blinding.
Apply those 4 steps and you are going to systematically dismantle even the most convoluted questions they can throw at you. But I'll leave you with one final provocative thought to chew on for your next study session. If a question shows a drug reducing myocardial infarction in men, but not in women, is that confounding or is it effect modification? You might want to dive back into your notes on stratification to find the answer for that one. Until next time, keep crushing those vignettes.